Good afternoon, and welcome to today's Lunch and Learn webinar for the Iowa Pediatric Mental Health Collaborative, Preschool ADHD Part 2, Medications in Depth, presented by Dr. Burgundy Johnson. My name is Coffee Dixon, and I'll be moderating this session today. I'll cover a couple of housekeeping items before we get started here. The webinar will be recorded and made available for viewing on our YouTube channel. I'll send the link to our YouTube channel and the follow-up email after the session. Following the presentation, we'll have time for questions. So please use the Q&A feature in the webinar toolbar to submit your questions, and we'll cover as many questions as we have time for. Instructions for how to claim credit will be uploaded to the chat section. I'll also send this information in the follow-up email. Just to note, if you attended part 1 of the ADHD two-part series, you'll need to claim credit for that separately. So each of the sessions has their own evaluation and link to claim credit. So without further delay, it's my pleasure to introduce Dr. Burgundy Johnson. Dr. Johnson is currently the Division Lead of Child and Adolescent Psychiatry at Carle BroMenn Medical Center, as well as Adjunct Clinical Assistant Professor in Child Psychiatry at the University of Iowa Hospitals and Clinics. She did her Child Psychiatry Fellowship and General Psychiatry Residency at the University of Iowa Hospitals and Clinics. Her interests are community psychiatry, therapeutic approaches, and early childhood mental health. She lives in Iowa City with her husband, 2 sons, and 2 cats. So thank you, Dr. Johnson. I'll turn it over to you.
Thank you. Can you hear me okay?
Yes, perfect.
Perfect. Oh, my camera just super zoomed out for some reason. I got a new camera, so hopefully no one has a seizure as it zooms in and out. Anyway, okay. So yeah, thank you for that introduction. I am Burgundy Johnson. I'm a child psychiatrist, and today we're going to be talking about preschool ADHD medications. I don't have any disclosures to make. And let's see, basically we're going to be going over meds. So what we know about preschool ADHD, and by the way, I'm sorry, I made these slides super colorful. I guess if someone has ADHD, they might enjoy this, or if they have anxiety, they might be having a seizure right now with all the colors. But anyway, what we know about preschool ADHD largely comes from something called the Preschool ADHD Treatment Study, the PATS. It was a really well done NIH study that has had numerous follow-ups since it was originally done. They followed these kids over time who had ADHD symptoms to see what happened, see how they responded to things, and we got a lot of good information out of it. This is just some of the medication information from the study. So it is not everything we learned from the study, but for the medication part, this is what's good to know. Now, they used methylphenidate as the medication in the study, and what they found was that it was pretty much safe and effective for young kids. So they said that kids 4 and above do just fine with the medication, and when they're in the severe category of ADHD, they benefit from getting it early because of the preventative way that the methylphenidate can act. When we have these kids who have severe issues early on, they're just more likely to get in trouble later down the line. So they found that first line for severe ADHD was methylphenidate and therapy. And then for mild to moderate ADHD, it was just therapy. Now, in this, they used lower doses of methylphenidate. You can see here 0.7 milligrams per kilogram, plus or minus 0.4. I'll go into the dosing a little bit more, but this is what they found was effective in the study. They did dose it 3 times a day, and they found that young kids tended to have a higher rate of side effects than older kids getting the medication. Now, this talk is about medication, but I don't want to minimize the role of therapy with kids who have ADHD symptoms in preschool. So first line for all of them is therapy, generally behavioral management, parent management, and then what happens is when we get to that severe category, the severe ADHD in this age group, that's when we also add in first line is meds plus therapy. Or if the child has failed numerous interventions already, then that also might be the time to do medication in addition. Um, Now, I sort of mentioned this, but why? Why do we want to give young kids a label and give them a stimulant? I hear that a lot, like, doesn't that seem mean or unfair? Or my cat came to visit, or does it seem like we're maybe making that call too early? And yes, it's true. Something like 70% of preschool kids were identified as having hyperactivity. So we can see a lot of ADHD symptoms in these young kids that does not end up always being ADHD. However, the difference is that what we found with the PATS is that the kids who fell into that severe category early on, so, between 4 and 6, they had severe symptoms of ADHD. They were no, like pretty much at any age, they were going to go on to get that diagnosis of ADHD. So we could have waited 2 years, 10 years, and they showed all those kids ended up having a diagnosis. So they determined it was valid to say those kids in the severe category have ADHD early on. We might as well give them a label because then we know what we're working with because it's going to happen for them. And then also, there's so many potential problems with ADHD down the line, the morbidity, mortality, the accidents, the psychosocial impacts. Like there are many strengths to ADHD, but there are a lot of potential problems that can happen. They have found that when we have the youngest kids with the most ADHD symptoms, they have the worst potential outcomes. I'm sure for multiple reasons. The ADHD is interrupting their development at a younger age. They potentially have more of a spiral. So it's worthwhile. I mean, again, some people are like, oh no, a stimulant for a young child seems scary. But with these kids, I mean, we are looking at really bad things potentially down the line. And so a stimulant can actually keep them alive. So in that case, we found it's worthwhile diagnosing them and it's worthwhile treating them. So, all right, let's get into the FDA recommended med options for ADHD. I'm not going to go into other things, other treatments or we could talk about omegas or saffron. There's plenty of discussion for that, but I'm going to stick to just the real main recommendations. So, getting into stimulants. Now, it's interesting. Stimulants work by treating, letting a child have more norepinephrine and dopamine. So ADHD is actually thought to be an adrenaline deficiency, which seems counterintuitive because a lot of times these young kids seem like they have a lot of adrenaline. And what is happening is it's just like how people who are dehydrated will be thirsty and crave water, or people with low blood sugar will want to eat or crave sugar. That's what's happening with these young kids is they have that adrenaline deficiency and their body is trying to get more adrenaline. And what does that look like? That looks like they are being provocative. They are, being hyperactive. They're being impulsive. They're being dramatic. Basically, they're finding ways to increase the adrenaline subconsciously. They don't know that they're doing this. This is their body trying to treat itself. So that's why, interestingly enough, we give them adrenaline and they calm down. Now, I'm not going to go too far into psychopharm here, but basically, both methamphetamine and methylphenidate, excuse me, methylphenidate and amphetamine treat the norepinephrine and dopamine. It allows more to be in their brain. The only difference really is that amphetamine allows for more dopamine release. So we just see a little bit more of a punch of the dopamine with amphetamine. Otherwise, they both increase dopamine and norepinephrine. So an important thing to know is that stimulants are really effective, not just for preschool, I mean, across the board. We have such a high efficacy rate with stimulants. It's pretty amazing. I'm sure those of you who have prescribed stimulants see the kind of difference it can make. So the studies have indicated that between 65 to 75% of children treated with a stimulant experience improvement in their symptoms, and that's with the first medication. So that's great. So we can see a lot of improvement just with our first medication that we prescribe. So that's a very positive thing. Now, for those kids who don't respond, they found that the majority of those are going to respond to a second stimulant. Of course, there are always going to be kids that, maybe fall outside of that who are outliers, who need multiple medications or different things. But the great thing is we can see here, even just trying one or two meds, we can see an 80 to 90% treatment rate, which is very positive. So what are the advantages of the stimulants? They act quickly. So a lot of times I'll tell parents it's like Tylenol for attention. So they take it and it works at that time and then it's out of their system. It doesn't need to build up like they don't need to build up like the SSRIs, for example, that take time and you have to wait and see. Uh, there's more flexibility in that they can be used as needed. We can skip days. We can go for what the child needs. Do they need to be on it every single day? Do they need breaks? We can work with that. There are just a ton of different formulations and delivery methods now. So if you talk to people who were on stimulants a couple of decades ago or knew of people, oftentimes that scared people because it would zombify them or you hear these horror stories, at least I do. And I think that really ends up scaring a lot of people. And those things, they were true to some degree. So the problem was that we had limited versions, and now we just have so many different kinds of variations of the stimulant that we can usually find something that works for a kid without a ton of side effects. They may have a little here and there, but we should be able to find something where, the parent doesn't feel like they lost their child's personality or the kid feels sick all the time. We have enough that we can go, oh, you had that side effect. You know what? We're going to try something else that might work better. Um, Side effects are common with stimulants, but we've been using stimulants since the 1920s, even for ADHD. And even though we're only talking about it now, it's more in the culture now. People are much more aware. We've been doing this for a long time, and for the most part, just like the PATS study or the PATS indicated, is that they're pretty safe and effective. Of course, there can be lots of problems, but usually they're not too bad, to be totally honest. What are the disadvantages? So they don't work 24 hours. They're in and out. Usually, we get sort of a max of 12 hours. So that can be really hard if the beginning and the end of the day are problems. So if we see children who struggle, like the worst for them is the very morning and the very evening, we can make stimulants work, but honestly, that's tougher. That's often when we do need to go to the non-stimulants to be able to get that covered. There are extra barriers because it's a controlled substance, just makes for extra difficulties. It's complicated with insurance because that also often comes with extra checks and balances, especially with younger kids. I'm sure anyone who's prescribing them or taking stimulants probably knows that the shortages right now are a little bit bonkers and makes everything more difficult. And finally, we do see side effects, but they are often not too bad, but they are common. So it is common that you're going to see a side effect with starting a stimulant. Now let's get back into treating the preschool age. So we have a gazillion stimulants now. That's great. For the most part, I would recommend, and what I do is I only ever do immediate release as the first line in a child who's under 6, or I guess under maybe 5.5. I might fudge if they're over 5.5, because for multiple reasons. Because the studies used immediate release, so we have all of our good data from those big studies. It was immediate release stimulants, and then also that's what insurance will end up covering because of that. So if you try and do an extended release, it's harder to get really good data to convince insurance companies, whereas I'll get into it, but we can convince them for immediate release. The other thing too is that with these younger kids, they are more unpredictable in their side effects and their responses. So there is, of course, always like a bit of an art to prescribing meds in psychiatry, but there's even more of an art with these kids. And by that, I mean, it's more, I don't know, surreal or abstract because we don't always know exactly how they're going to respond. They might respond a little bit differently. The nice thing with the immediate release is that we can work around that a little bit. Like we can try and come up with something that's right for the child. So an example would be most kids up to 6 take a nap. So they required it at most daycares. They often have it at schools. So if you think about it, if you start a kid on an extended release in the morning, there's almost no chance that they're going to nap, so that can be problematic for various reasons. However, let's say they're on immediate release Ritalin, they can get that morning dose, and then maybe they have a nap 11 to 1, and then we can, instead of saying, oh, at lunchtime, what we can do is we can say after nap, so it doesn't interrupt that nap. So there's just a little bit more pliability. The other thing too is if they have side effects, it's really hard if we start them on an extended release, because then we have, I feel like sometimes I've seen parents traumatized because the medication is in their kid's system for a long time if it's extended release. And if they're having side effects, it's like, oh, my child was the devil for the day. And that can be overwhelming. However, with the methylphenidate, the nice thing is that if it's 4 hours, let's say they do have side effects, it doesn't work out, that's going to be a lot shorter of a time when we see those side effects, those initial things. So now out with the PAT study, they used methylphenidate. Now, I don't know exactly why they chose specifically methylphenidate, or I don't remember, but that is what they ended up using. And they used it on kids 4 and above, although there is data to say that we can diagnose ADHD in kids 3 and above, and we can use medications. Point being, our big landmark study used methylphenidate. So that's what I usually recommend starting with. You can see here, I don't think I've ever started a kid under 5.5 on a long acting. I don't think I've done it because of all the reasons I mentioned before. There'd have to be a good reason. However, very often these kids will eventually get to a long acting for various reasons. Maybe they don't want to take it at school. They've, grown, and they'll do better with a certain kind of extended release. There are lots of reasons. So chances are you'll eventually get to an extended release, but I would not start one. So let's touch back a little bit about that insurance issue. Oh, this is where it gets a little bit complicated, because Adderall immediate release, believe it or not, is FDA indicated for age 3 and above with ADHD. So they got the studies, they have the indication. However, Adderall immediate release tends to be a little bit, on average, it's not tolerated as well as methylphenidate in these young kids. It just seems to have some more intense side effects. Not huge. It's not like, oh, we can't use Adderall, but it is a little like, ideally, methylphenidate would be the one with the FDA indication at 3, not Adderall. Point being is it's safe, but it does seem to be a little harder on kids. Now, what's interesting is that methylphenidate is FDA approved for age 6. Now, Adderall is the only stimulant approved under the age of 6. So it's just that one. And maybe little variations of it, but from the amphetamine branch. Methylphenidate FDA approved for age 6. However, because the PAT study says 4 and above is safe and beneficial, we start to get a little bit like, well, then what should I prescribe and what's going to be covered? Now, this is where it gets more complicated, is that the insurance companies, so let's say we start methylphenidate, it's indicated, you're doing the right thing, they will write back and they say, not covered because the child's under 6. Well, now we're in what do we do now? What I always do, and I have generally always had luck with, is if you try and overturn the denial, what you do is you just send a copy of the PATs and say, it's been well studied, it's well documented that it's safe and efficacious in this, the severe group of kids, which is the child that we're prescribing. And then you send that to them, and at least that's what I do, and I almost always get approval. I don't recommend ever doing a peer-to-peer on the phone, only because it's a similar process, except you might randomly be put on hold for 6 hours and then someone hangs up. So there's a little bit of a danger with the phone there. I usually prefer documentation, because here's the thing. I have spoken to pharmacists at the insurance companies. They know that this study exists. This is not like insurance is going, oh my gosh, you can treat children this young. I don't know if I believe it. No, they know. They know this study. I know because when I've called and spoken to them, they say, list a study. And I say the PATs, and they go, yep, check. They say, yep, that's on the list that says that you can do it. So it is a bit of they're not doing it because they don't know. It's a check and a balance, I guess you could say. Um, what I would recommend doing is when you have a young kid, if it's between 3 and 4, just do the Adderall because the PATS doesn't do Adderall. So we don't, there are studies out there showing Adderall's okay, but to get insurance to approve it, the easiest would be the FDA, age limit being 3, they almost always approve it. It has to be immediate release. Extended release is age 6 and above. Since Adderall is not always tolerated as well, I would say I have maybe, I don't know, a quarter of kids who end up staying on it for longer than a couple of months because they do well on it. But usually young kids, they struggle with tolerating this. What I tell parents is, yes, we're gonna have to do the Adderall, whether you like it or I like it, and maybe it'll work out great. And if it doesn't, because of how quick these medications work, the child can have one bad day and we can say, a really bad day, and we can say, see, they failed the medication. It might be different if this was an SSRI and they are still depressed over 2 weeks, but we know if it's going to work or not. And if it causes severe issues the next day, that's enough to take the child off of it. And then at that point, they have failed that medication, which was the first line, but they still need meds. So then insurance will cover what we need to ask for next, the methylphenidate. Um, Another thing is sometimes the parents will be paying out of pocket for methylphenidate. I've come across this usually a couple times a year where parents will tell me that their child's on methylphenidate from the PCP or someone, but then insurance doesn't pay for it. And that's because they require usually this stepwise therapy. If you want to get the methylphenidate covered, all you have to do is send the Adderall, and that's all, that's the check that it takes for then if we need to go to methylphenidate, then it gets covered. Of course, if they fail Adderall, clearly if they don't fail it, there's no reason to switch. Um, but so I would say don't get caught up in letting parents pay for it when there's a pretty easy mechanism to get things covered. It's just no one talks about this expectation of how we're supposed to prescribe them. So now, speaking of prescriptions, these kids are more likely to have side effects from stimulants. I think that makes sense. People know younger kids are very sensitive. What's interesting is that a lot of us, I think, have the idea that the non-stimulants are going to cause fewer problems. So we might say, stimulant seems kind of scary. I don't know if I want to start a 4-year-old in that. So maybe guanfacine or Strattera seems a little less scary. Yes, in older kids, they have side effects with the non-stimulants, but they're usually not as much as the stimulants. What's interesting is because these young kids are so sensitive, they pretty much have the same rate of side effects with non-stimulants and stimulants. So you are not going to necessarily get away with them doing better. I'm not saying that's not a reason to trial the non-stimulants, but there's a good chance that you will still get a response. Just for example, usually guanfacine calms kids down, right? The young kids, they have paradoxical responses to guanfacine. I still prescribe it, but I have had so many young kids who start biting and crying and becoming emotional wrecks. Probably maybe a third of the time I prescribe guanfacine in kids under 5. So I still do it. It's still worthwhile trying, but I go over that with parents, so this would be a time where if a parent comes back and says the guanfacine made them go crazy, it might be our gut instinct to go, oh no, that wasn't the guanfacine. And if the kid were older, maybe. Younger, it's likely. I'm sorry for all the text on here. I don't know which is worse, all the colors or just black and white, lots of text. But uh, before we start stimulants, there are a couple things you have to do and a couple things you don't have to do. We don't have to get routine blood work. We don't have to get a routine EKG. The stimulants, they've been like, there's still studies coming out in the stimulants. We're still learning more, but we've basically shown that we don't have to be too worried about their cardiovascular profile. Even though it sounds scary as a stimulant, for the most part, the way that they're prescribed and packaged, we do not see increase in cardiovascular events. So we don't have to worry too much. We might want to get an EKG if for some reason we're prescribing a high dose, or if there's a blood pressure change, pulse change, things like that. The other time that we'll want to check stuff out is if there's a history of sudden cardiac death in the family. And the way I describe that to parents is not just like, an older person had cardiovascular disease. We're talking about someone young who dropped dead. Like when you hear about those football players who are out playing and healthy and then they die. That is the kind of genetic cardiomyopathy that we don't want to miss in children. And it's not common, but that kind of history we'd want to send them to a cardiologist first to see if there is something genetic going on. Also, if there's a known cardiac issue, if they have a hole in their heart, anything like that, then very often we want to send them to cardiology first. If it's something like they had a tiny hole in their heart when they were born and then it closed up, you hear things like that, and it does happen. And since then, they have not had a murmur, there have been no problems. That would be a situation where, if you're skittish, you could send them to cardiology. But I would think an EKG at that point would be enough to say, okay, it's fine. I will be totally honest with you. I don't know if we have any cardiologists here today, but every kid I've ever sent to cardiology has gotten approved for a stimulant. They have never turned me down on starting a stimulant. There might be like, oh, do this or do that or whatever, but I have had kids with some interesting things and cardiology approved and they did fine. So try not to get too anxious about it. When the kids are on the stimulants, they can have a small increase in blood pressure and pulse. Usually it's more often pulse. We see normal tachycardia more often. Those symptoms can actually persist 3 months after the child is off the stimulant. It doesn't usually, but it can. Usually if I see big changes in blood pressure, or if I see a rhythm that is not normal and tachycardia, those would be situations where I would usually stop the medication and then also potentially follow up somewhere. Usually with kids, I rarely ever see actual blood pressure problems with kids on a stimulant. Hardly ever. Adults, yes. Kids, no. Their bodies just respond so well. They're so much more, pliable that they can tolerate the change in the vascularity. So usually when I see blood pressure, more often than not, it's actually another primary problem. There's a primary issue going on. So maybe a kidney issue, a heart issue, and then the stimulant is adding to it. So I usually end up sending them to nephrology to check out the high blood pressure. All right, side effects. I already mentioned we have lots of side effects with the stimulants, but they're usually pretty well tolerated. Those of you who prescribe them see this. It's like, oh, yep, lots of people have slightly worse sleep or a slightly lower appetite, but it ends up being pretty tolerable. You can see here, it's just a little bit of everything. Decreased appetite, sleep disturbance, headaches, drowsiness, all of it. Now, what's interesting is that I tell people like the biggest things, usually the most common, lower appetite, problems with sleep. What's interesting though is that stimulants can actually improve sleep for kids with ADHD. Now, this isn't across the board, and I don't know when I'm going to have a kid like this or not, but they did a study where they gave stimulants right before bed, and some kids with ADHD, actually a decent amount, slept better. I'm not recommending it. I don't do it that way, but it's like how some people take coffee naps. What happens is these kids, they're getting what they need and they can regulate better and sleep better. It's really interesting. So I tell parents, yes, pay attention to if they can't sleep, but also there's a chance they might sleep better, and I do see that. When it comes to height and weight, they can be delayed. So we can see a little bit, I guess I would say like stunting of the growth, but it's not permanent. Usually it's just time limited if we see that while they're on the stimulant. And then once their body either gets used to the stimulant or they come off of it or they go through, puberty, then they catch up. So for the most part, we don't see any issues except for potentially temporarily. There are some studies that indicate that stimulants can make kids up to a half an inch shorter with their final height. That's not every kid, but it can happen up to that. For most people, that's usually not a big concern. And honestly, I track growth curves and I don't see big concerns with growth too much as long as we're paying attention and changing things when we need to. So one thing I wanted to throw out here, I couldn't figure out where I wanted to put this in the slides, but something that I have parents ask me not infrequently is, okay, if we give our kid a stimulant, is that going to set them up for being like a druggie? Are they going to look like a druggie? Are they going to be addicted to stuff? When they get older, is it going to mean that they're more likely to do drugs? Often that's in families who've been affected by substance abuse and they really don't want to see their kid go through that. But also, it is scary. I mean, Of course, I had to accidentally say methamphetamine instead of methylphenidate in the beginning of this talk. But that's the thing is stimulants kind of come with we have street stimulants and prescribed stimulants, and sometimes people think that they're the same. Maybe at base they're the same, but they're much different. Um, what they have found is it's actually quite the opposite. So I think it was out of Denmark, someplace Scandinavia, where they have these great records of the whole population. They did a bunch of big studies there, and they've repeated these kinds of things in the US. And they found that most the people who were treated appropriately with stimulants who have ADHD when they're younger go on to be less likely to abuse substances, which is great. And there are multiple reasons for that. If we take a kid, let's say we take a 15-year-old, it wouldn't make sense if it were a 4-year-old, even though that's this talk. Take a 15-year-old and they're at a party and someone passes them a drug. The kid with ADHD who's untreated is more likely to impulsively go, okay, and eat it, right? Here's a pill, take it, I did. And then, I mean, it's a slippery slope because they're impulsive. The kid who is being treated with a stimulant has a more fighting chance to stop and think about, do I want to take this thing that someone handed to me? I mean, it's almost as simple as that. But beyond that, if kids are getting their deficiency treated appropriately, then they don't need to go around and secretly get it from ways that are going to hurt them, illegal ways. So the nice thing too is that I don't know what it is, but the way that they package stimulants for kids and the way that we dose they do not cause euphoria. It's not like cocaine or snorted things. It is not meant to cause euphoria. It's quite the opposite. And I'm sure lots of you have seen this. It calms kids down. We don't see them, acting high. We see them doing their work. And what ends up happening is that because we don't have that whole aspect to it, a lot of times kids associate being on a stimulant as they grow up as kind of boring and they don't really like it. Oh, this is the thing that made me do my work better and that my mom made me take every morning, even though I didn't want to get up. So very often we see these kids who they don't get the drama from abusing this because they already have like a very boring, annoying association of it. It's just another pill, and why would they want to do it? So a lot of times when I see parents who are treated as kids, they're like, ugh, stimulants. It's not like, ooh, stimulants. So I wanted to get into the differences between all of the stimulants because even though we may not be starting with extended release, certainly a lot of kids do end up on it. Even if it's when they're in preschool, they might end up on it. But usually, point being, it's important for you to know. So just some basic stuff. All the stimulants derive from either amphetamine or methylphenidate. So they all come from our mother and father here of the stimulants. It's all based off of these two. And then everything is just slightly different, packaged differently, different amounts of extended release versus immediate release. And I don't know, for me, I would think it wouldn't make a difference, these small changes to the same two base drugs, but it really can. If you guys have seen even one kid on a stimulant that's very similar to another stimulant, they can have such a different reaction because there's so many different kinds out there that we can individualize it to the kid a little bit more. Now, one thing that I just want to put as a note here, and I don't know if this is helpful to you or not, but I tend to say the brand names a lot, not because I love the brand names or I think that we need to only dispense brand names. I say the brand names because unfortunately the generics kind of all sound the same and they're not all the same. So when we start talking about methylphenidate extended release, and we might say HCl or, intermediate release, things like that, they sound the same. And they sound the same to me. So I think they really sound the same to parents. So when I get a parent that, transfers to me and they go, well, they're on methylphenidate. And I say, okay, immediate release or extended release? They go, I think extended release. And then I say, which one? And they say, I don't know, it's something like 20 or 25. Well, for me, that could mean, okay, is this Metadate? Is it Ritalin LA? Is it Concerta? And it might be easy to think those are all the same. I mean, I guess they are with the base medication. But what's interesting is I love looking at these curves. These curves will provide you with so much information. If you type in the stimulant that you're interested in looking up, so, Concerta, Metadate, whatever, you can find these dose curves at how they affect the body online. And you can see here, they really are different. So right here, this is a graph, and I'm sorry it's like poor quality, but you can see it's Ritalin LA versus Metadate CD20 versus Concerta 18 versus Ritalin SR20. These are all methylphenidate extended release, essentially. Um, but look, this is how, so this is the concentration over time in a kid's body. So you can see here they are working a little bit differently. Like, yes, they may eventually have the same dose and the same, effect, but like if we look at, for example, Ritalin LA, so that's the one with the round dots here. You can see here there's a little spike and then there's a dip and then there's a bigger spike. It's very it's almost severe in how it comes on and off. For some kids, they're going to feel that and it's going to be uncomfortable. So you might be, a lot of times I can associate with how the kid, like how their symptoms are changing throughout the day. I can associate it with the curve pretty well. So like in this situation, it might be like, oh, a parent comes in and they say, my kid does really well for the first 3 hours, 8 to 11. And then they suddenly like start acting out and they're getting in trouble in the class right before lunch. But then they go to lunch and then they do better. And then they get their stimulant later and they do even better. But it's weird because in the middle of the day, they're not doing well. Well, if this kid is on Ritalin LA, maybe they are responding more intensely to that dip. So you can see here, maybe that's just kind of too much of a dip for that kid. So we might want to switch to something that's a little bit more smooth with the on and off curve. So then you might say, okay, well, let's look at something like Metadate CD. So that's the one with the squares. I know it's hard to see, but it's much more of a gentle curve up and down. Now, the interesting thing is that may not work for some kids because they might need the punch of the stimulant to pay attention. So some kids, when it's too smooth, they don't even feel like anything's happening. So it's interesting if you at any point you look these things up. I talk to a lot of parents about these. I will show them the curve and I'll try and associate it with what they're explaining to me, what they're seeing in their child. And it really does fit more than I would expect. Um, so anyway, I really recommend when you get a chance, just even having fun and looking it up because you'll go, oh, okay, that actually is the difference between Concerta and Metadate. I don't know if anyone, no, they probably did teach me that in child fellowship, but I feel like we don't actually talk about it. People just kind of pick their favorite stimulant or the one they know they'll get approved or whatever, and they go, okay, that's what I prescribe. But really, there are differences. So what's interesting is for the immediate release, they tend to be pretty similar. So amphetamine, methylphenidate, they all last. So usually Ritalin is like 2 to 4 hours. Amphetamine's more like 4 to 6, but it depends on the kid. Their metabolisms are just so fast and they're so variable that it could be an hour and a half for Ritalin for some kids, or it could be longer. But there's much more of it's a very strong spike on and off for this limited amount of time. Whereas when we look, ooh, I didn't put it here, but if we look at, I'm going to come upon it later. Sorry about all that. So if we look at the extended releases though, you should pay attention because like for example, Metadate CD is a shorter acting extended release, which you may not know if you just say, okay, I'm going to do 20 milligrams compared to Concerta, which lasts a couple of hours longer than Metadate CD. I had an experience of this where I had a kid who I saw who came from Europe on a stimulant. And it's a stimulant we don't have here, but it's essentially a methylphenidate product. Now, he was on 20 milligrams of that methylphenidate product. The PCP very appropriately wanted to get him on the equivalent medication here. And I'm assuming what they did was they said, okay, he's on 20 milligrams. So I'm going to put him on the equivalent of 20 milligrams here. They're all methylphenidate extended releases, right? What was different was that the one that he was on happens to be, I think it's almost longer than what we have here. When I looked up the research, it was one of the longest acting stimulants I had seen. And then that person said, okay, I'm going to put them on 20, and they put them on Metadate CD, which lasted quite legitimately half the amount of time as the one that this kid had been taking in Europe. So when I saw them, they were having a lot of problems in the afternoon. It was just like this kid was acting out. They wanted to know if it was a problem because he came from Europe and he's having problems transitioning. And when I looked at the curve, I was like, oh, I think I might see the problem because it's not just the dose, it's that other stuff too. So let's get into the nitty gritty just a little bit. I want to make sure I save some time for questions. I have a lot of extra information on slides here, but I made sure to go over, I think, the big stuff in the beginning. So whatever we don't get around to, you can get the slides, but it's not a big deal. So when we are starting to treat severe ADHD and we want to use a stimulant, I recommend start BID dosing morning and lunch, but you might have to go to TID. This is something to keep in mind. Adderall, if you're going to do Adderall, it's twice as strong as methylphenidate. And that goes pretty much for the majority of Adderall products and methylphenidate products. So amphetamine is just, it's twice as potent. It has more dopamine. So this happens to me probably once a year. Probably once a year where I will have someone comes to me as a psychiatric consult and they were originally on, let's say, Ritalin 20, and then they weren't doing well, or they're having problems, and their PCP put them on Focalin 20 to see if that was better. Now, here's the thing. Pretty much you can follow the same rules. Adderall products are twice as potent as methylphenidate products. However, there are two exceptions. Vyvanse is a amphetamine product that is dosed like a methylphenidate because it is half as potent. So it's the different one in that. And then Focalin is a methylphenidate product that is twice as potent as most methylphenidates. So it is dosed at what we normally do half of the other methylphenidates because it is much more potent. So it's the exception. Vyvanse is the exception. So what had happened was, it's funny because I was talking to this parent who was like, oh my God, my kid did way better on the Focalin. Like they do great. You know, that switch made all the difference. And I was like, it's true. It might be the Focalin that's helping this child. Or essentially what the PCP had done without realizing was they doubled the dose. If they went from Ritalin 20 to Focalin 20, that would be the equivalent of going to Ritalin 40 because of how they're dosed. So yeah, of course, as long as the kid was doing fine, that's fine. But that's sometimes I have to explain to parents like, okay, it may not, like, yes, maybe the Focalin's helping them, but it's possible that it's actually they needed a dose change. So keep that in mind when you are switching. For the most part, you can usually guess the Adderall products are just going to be twice as intense. So if you want to switch to an Adderall product, so long as it's not Vyvanse, because that's different, then you pretty much just, you can start by cutting it in half. You have a kid who's on Concerta 54 milligrams, you want to switch them to Adderall XR, you can start like, 20 milligrams or something, because that would be a very equivalent dose. And then you moderate it for, are they having side effects? Maybe you start lower. Is it doing nothing? Maybe you start a little higher. All right, and getting into the dosing, again, I'm sorry about looking at this, so many words, but I wanted to make it clear cut how I was taught to dose it. So, and these are general guidelines. Each child is different and it's not like antibiotics where you need to go by the weight. These are sort of general guidelines on what's going to work and what's recommended for the child's weight, but they're not absolute. What I was taught was that methylphenidate products in general, usually we're going to see a good treatment when the dose is between 1 to 2 milligrams per kilogram for the child. Now, we usually start lower. So usually when I'm starting a methylphenidate product, especially in these young kids who have unpredictable responses, I usually start with about 0.5 milligrams per kilogram. I tell parents like, hey, this may be great or it may do nothing. We just have to wait and see, but we have lots of room to go up usually. Also, if you want to make it easy, you could just start with the lowest pill dose. So sometimes when I see a kid and I just want to start with the lowest, I'll go, okay, we're just going to go to 2.5 BID because we can get 5 milligram pills. And it's almost always at least 0.5 or higher. So I never worry about the actual dosing. Point being, you want to start there, but then you increase as needed and as tolerated. So if there's a little bit of improvement with symptoms, not a lot of side effects, then that tells you keep going up because you're in the happy treatment range would be between 1 and 2 milligrams per kilogram. Kids can be different. You might have some kids where going up slightly above a homeopathic dose is too much for them, and it's just how their system works. You might have some kids where you can sock them with more stimulants than I can ever imagine, and they do just fine. There are exceptions, but this is the general guidelines. If you have a kid who is somehow at like 0.25 milligrams per kilogram of methylphenidate, and the parent says that the kid is acting out and they're worried it's the med, I usually tell the parent, no, the med is not doing anything. You're just paying attention to your kid acting out. That isn't always the case. It can be that, but I keep that in the back of my mind because usually like 70% of kids are going to do well in that treatment area. So a lot of times when I have kids who are very, very sensitive to meds and parents who are very concerned, they've had maybe negative responses, that is when I will go below this rule and I will do liquid methylphenidate because you can play around with it. And I'll do something like 1 milligram per kilogram and then escalate like, weekly. So I'll check in with the parent. So it's more touching base. It's more like a little bit more work. But instead of starting with side effects, we're gradually getting the kids used to it, and parents usually feel a little better. But then it also takes time. For Adderall dosing, start with 0.25 milligrams per kilogram, or you can just, generally go with Adderall immediate release 2.5 milligrams per kilogram because that's the lowest pill dose. So sometimes I just start kids on that because it's going to be the lowest we can get anyway, and they do fine. You want to start with that, and then Adderall range for treatment is usually 0.5 to 1 milligram per kilogram. Again, it is twice as potent, so we look at a lower total dose. Now, what's important is that these are all the doses added up. So what I want to show you here with the math, so let's say we have a 40-pound child, and that comes to 18 kilograms. So the way we would look at it is, let's say we want to do 0.5 milligrams per kilogram. That means, and we want to do it twice a day. So we would say, okay, we want them to be on roughly a total daily dose of 9 milligrams, right? We want them to be on it twice a day, so we would cut that in half. So then it would be, that's how I determine, okay, this kid's going to get 5 milligrams of methylphenidate in the morning and 5 milligrams at lunch because of this math. And then I will continually, each time I make a change, I will get the weight and see, it'll help guide me like, okay, this kid went through a huge growth spurt and now the meds aren't working. And the parent calls and I'm like, well, they gained 40 pounds and they grew a couple of inches. It makes sense why it's not working. We've suddenly dropped down to 0.5 milligrams per kilogram when they had been maintained well at 1.2 milligrams per kilogram. Or what about the kid that suddenly lost a lot of weight or something happened and now they're starting to act out? It's possible that that medication now is too much for them. So I always get the weight and double check. Now, I just want to touch on the non-stimulants. The big non-stimulants that we have are alpha agonists and the SNRIs, which I usually just think of as Strattera. I usually just think of Strattera as its own thing. And then they had Quellbury come out that's in the same class. So now I have to add a little bit more on that. But point being, alpha agonists are often what we go to if the child struggles in the morning or at night, or if for some reason there may be another reason too. Someone in the family has done well on it. Maybe guanfacine has been shown to help a little bit with anxiety, PTSD, ODD. Maybe we have some emotional stuff and we want to try this first. There are many reasons why we might actually start with it or end up going to it, or a lot of kids end up being later on guanfacine and the stimulant. I know we try and minimize how many meds a kid is on, but sometimes we can have, I think of stimulants and alpha agonists as the peanut butter and jelly of the ADHD world. They go well together, and maybe we can do littler doses and get fewer side effects and more coverage and more help. So the alpha agonists are usually pretty well tolerated, except for in these young kids. They might get cranky, they might get really tired. Part of it is just because the dosing, there's no liquid for the alpha agonists. There's no chewable. So we really are stuck with that baseline pill. And sometimes that's just too much for a 4-year-old. So let's say they have side effects on an alpha agonist. I warn parents, that doesn't mean that they can't ever do well on it. What it means is that they're too little for them to be able to tolerate this dose. So if you have a kid who you started at 4 on guanfacine and they totally flipped out, freaked the parent out, and they're like, I never want to touch that again. Well, that's okay. You don't have to. But it's important to also say, well, this was too much for their body at the time, but more than likely, if they grow up a couple of years, they will do just fine on it. So it doesn't totally rule it out. Um, I won't go too much into the dosing. If you really want, you can ask, but usually I start with 0.5 of guanfacine in the evening. And then after a week or two, I add the 0.5 in the morning. Now it's 8 to 12 hours is how long it lasts, which is why we dose it twice a day. One little thing with the guanfacine is that most kids need 12-hour dosing, or they benefit from 12-hour dosing. That's how we learn to prescribe it. So, 8 in the morning and 8 at night. However, there's a subset of kids, and I don't know why it's this extreme. It's like not in between, who process it at 8 hours. It's like not 9, 10, or 11. It's 8 hours. The way that you'll know you have a kid like that, that's not the majority, but it's probably 25%, is you will get a witching hour. So let's say you start the guanfacine at night before bed because it makes them sleepy. And then, you start in the morning and parents come back and they go, actually, the kid's doing really well, but from like 5 to 8, everything is just horrible suddenly. That tells you that you probably have an 8-hour metabolizer, and it's usually very easy treatment. You just move the nighttime guanfacine up to like 4 p.m. and they do great. So it's usually an easy fix. Another little point I want to make is that extended release guanfacine and Tuniv is not one-to-one dosing with guanfacine immediate release. Often it ends up looking like that when we switch the scripts, but just so you know, technically, 0.66 immediate release guanfacine equals 1 in Tuniv. And Tuniv is less potent. It is less strong. So if you have a kid who's sort of on, you need to go up on the dose, but you want to switch them to extended release. Let's say they're on 0.5 twice a day of guanfacine, and you're like, this kid might need more, but you know what? How about we keep the dose the same and we just go to the extended release, and then the kid does horrible. It's true. A lot of kids are hit or miss with if they're going to do well on immediate release or extended release. But what you've effectively done is on a kid who might need more, you've gone down 33% without realizing it. So that might lead them to not doing well. All right. Pros and cons. We kind of went over a lot of this, or I already mentioned it. It lasts longer. Less intense side effects, even though there may be still a lot of side effects. There are no long-term concerns. We don't have usually problems with appetite. I'm almost done, I promise. And then again, Strattera. I know it's an SNRI. I still think of it as just Strattera. It's like its own thing. Strattera, the good and the bad of Strattera, it is stimulant-like, but it doesn't usually cause as many problems as the stimulant, but it can. So it often doesn't cause appetite or sleep problems, but every once in a while in some children, it does. Strattera is like hit or miss. I don't know if you guys have found that. I have had some kids who just do amazingly on Strattera, and it always surprises me. And then I have some kids where it just does absolutely nothing. The problem with Strattera is that it takes a couple weeks to build up. That's not a problem, but if you have a kid who is destroying the classroom and is about ready to get kicked out of school, that I wouldn't usually go to Strattera next unless you need to. The other thing to keep in mind for the preschool class is that Strattera only comes in a capsule. So you better need your child to swallow capsules. So, okay, that is mostly what I want to go over. I do have lots of things here and there that are like little tips and tricks, but we kind of went over them. Again, Quellbury, I put a slide in there to be thorough. I have not prescribed it. It's been too expensive, so I don't know anything about it. I put slides on here for if you want to look later for little things that come up. Can't swallow pills, just so you know, methylphenidate luckily comes in a chewable, a liquid, and those are often not on a shortage. So if you have a kid and you send them the methylphenidate pill and it's out, just so you know, you can try one of these other ones and the pharmacy might have to order it, but they work just as well. Make sure you always ask if you have a young kid, hey, can they swallow pills? Unless you work with young kids regularly and you know automatically to just not assume that. When I first started, I had a couple of angry parents that were like, why did you send my 3-year-old a pill? And it makes perfect sense to me. We went over insurance, shortages. Oh God, I don't even want to talk about the shortages. Losing weight, that's a big thing that comes up. First thing you want to do if the kid's losing weight is try and get them to eat more calories. And by that, I usually mean protein, fat, things like that. What happens is, we don't want a kid to eat a whole bag of Cheetos to maintain their weight, But also, we don't want them eating fat-free yogurt and cucumbers to maintain their weight. That's not going to be appropriate. So first we push the food and they eat it at night. And I feel like PCPs and regular doctors and regular people say not to eat at night. The ADHD kids, that's when their appetite rebounds. So as long as they're growing, we let them eat. You can try switching a stimulant. I usually am okay if they don't go past 2 growth curves for losing weight. But if they start to, I switch them, or if they're already really low. So if they're doing great, you can consider adding cyproheptadine. So most of it is stuff that we have sort of touched on. One little thing I want to say is that ferritin deficiency is super related to ADHD. There's just study after study coming out saying this. And it both maybe contributes to ADHD, it worsens ADHD, and ADHD stimulants lower iron. So there's a whole relationship here that's very complex. Anyway, you should be checking ferritin. This is what like all developmental peds seem to do and sleep doctors. And you want the ferritin to be 50 or over, which is different than what we have in the system. But that is what it shows. They've shown that if we treat iron deficiency in a kid who is iron deficient and has ADHD, that often moderates how much stimulant they need. So it's nice to be able to pick up on that. All right, check for sleep apnea. A lot of kids have sleep apnea, and that could be contributing. And then that is about everything. We have 3 minutes for all of the questions in the world. I'm sorry if I was so monotonous here with too many colorful slides.
All right, so we'll dive right in to questions. Please feel free to type your question in the Q&A and we'll see how many we can cover. So we had several questions come in. One was, what testing shows dopamine release levels in the brain?
I don't know. I know that there are articles on this stuff, but I'm not sure how they got that stuff. I'll be totally honest. Maybe at some point I did. I can find articles and send them though.
Okay, well, thank you. Then there were a few questions related to like natural remedies or herbal, you know, so kind of, are those recommended, or are there anything that's evidence-based?
Yeah, so there's no herbal treatment that has been shown in research to be as strongly helpful as medications that we prescribe. So that's the thing is it's hard to argue with it because the stimulants have such high treatment rates. Maybe if they didn't do a good job, I would say, okay, that tiny potential help that they show with, let's say, omega-3 fatty acids, good for the brain, can be helpful. It is not going to necessarily treat really bad ADHD as strongly as a stimulant will. It won't hurt. It might help a little bit, but it's just not as strong. So same thing with most of the other over-the-counter things. It's interesting. They came out with a couple of saffron studies out of Iran that showed that they were as beneficial as stimulants. Now, I don't know because they have big saffron business there, someone told me. So I don't know if there's a bias, but there is emerging evidence about that. Magnesium has a little bit of data. All these things, it's kind of like a tiny bit, but nothing that like I as a psychiatrist would recommend. If a parent wants to try it, I usually say go ahead if you want to, and we'll see if it works for your kid.
Okay, thank you.
Mm-hmm.
Could the increased risk for substance use with kids untreated be linked to the impulsive choices associated with ADHD, or is it because by the time they're 15 and possibly in that situation, they have a better understanding of the effects of medications because they are so routine in their life?
I would say yes to the impulsive choices. So it's impulsive choices. So impulsivity is what gets ADHD kids especially into trouble. I mean, if they want to jump off a house, that is a potentially very dangerous issue. And if someone hands them a drug and they just start using it, it's the same. It's that impulsivity that's untreated that can lead to so many potential issues. And then if you think about it, there could be lots of other things. So let's say they are socially a little bit more awkward. They struggle with socializing, so they fall into a crowd that's not good, and then that crowd's more likely to peer pressure them to do meds. So all of it comes together, which makes it a little bit more complicated.
Okay, thank you.
Mhm.
Well, it looks like we've reached 1 o'clock. So I'll close with a couple of um, housekeeping announcements. The University of Iowa Carver College of Medicine is jointly accredited to provide continuing education for physicians, nurses, social workers, and physician associates. Um, so all other participants will receive a certificate of participation. Attendees are eligible to claim continuing education credit by completing the evaluation and downloading their certificate. And I did upload the instructions to the chat. I'll also send these in the follow-up email shortly. For questions, you can reach out to me at Kafi-Dixon, Kafi-Dixon at uiowa.edu. So in closing, I just want to thank Dr. Johnson for doing this two-part series and all the information she provided. And thank you all for attending. Thanks, everybody. Have a great afternoon.
Have a good weekend.